So then before we get started, I'm really happy to actually formally introduce Dr. Cristina Aamot. She has served as an adult geriatric NP BC with the Orange County Jail since 2011. During a hiatus from her career as a correctional health care provider, she has been employed by CareMore, a Medicare managed health care company in their CareMore Touch department from 2009 through 2011. Her professional trajectory has been marked by continuing education throughout, enrolling in a doctoral program in 2015. She had the honor to serve as a mentor for aspiring NP students within the UCI School of Nursing in the 2016-2017 academic year, as well as a clinical structure for the Bachelor of Science in Nursing program for Cal State Long Beach, her alma mater. Recently, she became a board-certified psychiatric mental health nurse practitioner, or PMHNP. Currently, she practices as a PMHNP at the Orange County Jail and assists in training newly hired providers. Dr. Aamot works at the forefront of healthcare delivery in the correctional setting, pulling from a range of expertise and skills shaped over more than 20 years of nursing experience. Welcome, Dr. Cristina Aamot.
Thank you so much. It's such an honor to be doing this again, to edify and elucidate some of the aspects of providing healthcare in the correctional setting. I know that for a lot of people, it's quite a mysterious workplace and can be intimidating. You know, while Sheriff's Department has had its share of controversy out there in the media, I am here as a representative of the healthcare agency. We'll share a few of the aspects of providing care for the jail population. Can you hear me okay? I just want to make sure the sound is okay. Perfect. Excellent. So my next slide, I had to put this in. Well, in celebration of the upcoming Earth Day, but also spring for me, it's a photo from my garden, by the way. It's a sense, it gives a sense of renewal, of hope, I believe we all need a little bit of that sprinkled with a feeling that we're going to overcome the challenging pandemic days. So I'm going to go through a few slides that, describe the layout of the Orange County Jail. So basically, currently there are two facilities that belong to Orange County Jail, the Sheriff's Department, located in Santa Ana and Orange. The main jail and intake and release center are in one compound located in Santa Ana. They house approximately 900 males and 190 females. And the Theo Lacy facility in Orange is a bit larger. It's right across the street from what is called a block. And by and the classification and housing are determined by a lot of factors such as institutional behavior, safety, violence, risk, escape risk, gang affiliation, medical and mental health considerations as well. Of course, there's general population, protective custody, high security, individuals with mental health disorders, and they are housed in areas that range from one bedroom to one dorm with one bed, and to rooms that accommodate two individuals, 4, 6, or even larger dorms. The jail population with mental health and medical disorders are housed in areas that are able to directly address their medical or mental health needs. Of course, we have ADA compatible cells and one-person cells for patients with severe mental illness. Okay, so this is a little demographic. The darker shaded area, I'm not sure what happened with my legend there, but anyway, the darker shaded area reflects the male percentage, and the lighter shaded area, the female. So while the Orange County has a fairly well represented demographic in terms of racial distribution, the jail population is overly represented by the Hispanic and Latino or Latinx demographic. And then you have a breakdown for the African American, Caucasian, and Asian population as well. Um, and I just did a little split on age groups. So the majority of individuals who are jailed are in between, well, yeah, they have to be over 18. We don't have juvies in our institution, between 18 and 50 years of age. Now, most individuals who are brought into jail do not have any form of health insurance. About 41% report some type of coverage, and that's mainly CalOptima. This reflects again the very tenuous primary care in a community, and the fact that the jail population is the demographic that is the highest user of the emergency room services. And of course, this is reflected by a compendium of adverse socioeconomic indicators that lead to poor health access and negative health outcomes. And some of these indicators are employment. A lot of the individuals who are brought to jail have been affected by the pandemic and closures in the community, so they're unemployed. Education, a lot of them are high school graduates or have GED. The income, of course, community safety, and social support. According to Title 15, Division 3, Chapter 2 in California Code of Regulations stipulates provision of healthcare among all incarcerated population and accommodation for disability and special needs, including psychiatric care. And this is a document that guides the healthcare delivery model and the imperative of providing healthcare in correctional setting. Now, since we do have, or we have had electronic healthcare record ability for the past 6 or 7 years, we are adding a variety of elements and component factors and metrics, I'm sorry, into the healthcare record. And we're collecting data on health insurance coverage, on housing, and other metrics related to mental health and medical health history. The case management of correctional health services initiates the CalOptima application for individuals who may have lost coverage or who seek enrollment after their incarceration period. There is now a discharge planning process where a release nurse, registered nurse, is coordinating aspects of discharge planning for the individuals into the community, including a package with the resources for housing, clinics, local clinics. If they do have mental health, psychopharmacology on record that is current, they do get a 1-week prescription for the medications they are currently taking in the jail. In addition to the registered nurse that coordinates this discharge planning, there's also the Jail to Community Realignment Program, or JCRP, that assists with a discharge planning for patients with mental health disorders by providing referrals to full service providers such as telecare, opportunity knocks, and linkage to other community resources for housing and job placement. Now, the Orange County Jail Correctional Health Services, we're employed by the healthcare agency, and we do have several health education and promotion strategies, the primary prevention. I have outlined a few here. Educational videos that deal with drug addiction, opiate overdose, and various interventions in cases of respiratory distress. Lately we have been playing within the housing areas of the Orange County Jail films regarding COVID-19 vaccination and information on the vaccinations and safety. There's posters on infection control and prevention, health promotion, education, anything from cold and flu prevention to basic hygiene and universal precautions such as wearing gloves. Well, not for the jail population, but for the nurses mainly. But hand washing, keep safe social distancing as far as the jail confines can allow. Educational pamphlets on a variety of health um, states do exist in all housing areas and in the areas where healthcare is provided to the jail population. Some of the secondary prevention strategies are screening for sexually transmitted infections. These are offered at almost all encounters with the registered nursing staff and are ordered and performed by the outside lab at UCI or Public Health, Orange County Public Health Lab. We do perform annual screenings for tuberculosis, cardiovascular disease, and colon cancer, suicide risk assessment for individuals who are at risk, um, and support groups provided by mental health clinicians in areas where the jail population with mental health illness resides. We also provide facial coverings for all jailed individuals, sanitizing stations and supplies for maintaining good hygiene while they're in their incarceration time, during their incarceration time. Of course, during the sick call or the face-to-face encounters with our jail population, we do discuss all providers, the licensed vocational nurses, registered nurses, do discuss lifestyle behavior modifications and set realistic and achievable goals for the individuals we're encountering. Very important to consider socioeconomic and cultural backgrounds and factors influencing their decisions for healthcare, and to be aware of each individual's unique history. A history of microaggressions, of dysfunctional families, of adverse childhood events, of social and economic disenfranchisement, the fact that most of them have a very tenuous safety net, and the history of substance abuse and everything that entails in terms of making decisions for healthcare and lifestyle, of course. During our encounters with the jail population, we strive at reframing the approach to patient care by considering all these elements that are inherent to jail population. Also assessing their readiness for change using motivational interviewing, employ elements of trauma-informed care while focusing on safety, on respect, acceptance, on an environment that contributes to empowerment, and also presenting with choices as far as their healthcare and mental health needs. Encourage support and acknowledge effort and achievement are very important elements of interacting with individuals who have, again, a history of trauma, of disenfranchisement, who may not benefit from the elements of respect and safety than most individuals do who live in a society. And I'm referring to the majority of individuals who are in jail, who are homeless, have been transient for a very long time, who have lost a sense of hope, of social reintegration, who have been marginalized and who have suffered a variety of microaggressions. Communicable diseases, of course, the risk of communicable diseases is really high due to the inherent incarceration and the housing aspect, communal living. Tuberculosis, influenza-like illnesses, chickenpox and measles are the most common ones. Fortunately, not very prevalent because we have a very good system at preventing and intervening when active cases of, let's say, tuberculosis or influenza-like illnesses have been detected. A person who comes into Orange County Jail and is booked will have one view chest X-ray to rule out tuberculosis, and of course any other diseases such as congestive heart failure if that's detected, or other health states. The chickenpox and measles would be very difficult unless we do have an active case. And we have had situations in the past where we had cases of measles. Those were fortunately immediately detected, and measures of mitigation of spread have been taken right away. And we do provide the vaccines as well for the chickenpox, varicella vaccine. The SARS-CoV-2, of course, has been a challenge since the beginning because again, due to the inherent communal living, the risk of spread of the COVID-19 has been very high from the very beginning. So some of the guidelines applied since the recognition of this pandemic and its virulence have been based on the public health department recommendations. And we have been very successful at curbing the rate of infection and mortality and morbidity. The approach to containing the spread of SARS-CoV-2 has been from the very beginning. As individuals are brought in, we are quarantining them for 2 weeks, and we're doing an initial Binax test, rapid test to see to rule out a positive case. And then after 2 weeks of quarantine in single cells, we are performing another COVID test, PCR, and then rehousing the individuals in the housing where their particular category dictates. Based on the finding. Currently, we do have 1 or 2 positive cases that are under, and these individuals are under isolation protocols. The Orange County Jail rate of infection has, in a sense, mimicked the community in the rate of increase, and that was immediately after the holidays at the end of the year, beginning of the year. However, now we have the lowest of infectivity rate we've had since the beginning of the pandemic. The Correctional Health Services follow the Orange County Vaccine Task Force. And as far as administration to jail population, as including patient education regarding vaccine safety, and then the criteria for the vaccination meets community standards. This slide is not updated. As of last 2 weeks, we have included all our population in the eligibility for receiving the COVID vaccine. Now, unfortunately, due to the temporary recall of the Johnson & Johnson vaccine, That has been the main vaccine offered in Orange County Jail. We are now offering Pfizer to a limited segment of our population, especially the individuals with the comorbidities and who are maybe at high risk for mortality should they get infected while incarcerated. Um, Education on the COVID-19 prevention and vaccination is a priority for all individuals returning to the community. We are providing, upon release, information on free clinics and sites of vaccination should they opt for continuing that or getting the vaccination in the community after their release.
Dr. Aamot, a question from the audience.
Sure.
Was your process on how to distribute vaccines federally guided or guided by the Orange County Healthcare Agency?
By the Orange County Public Health Agency.
Perfect. And I just
So,
want to add there that that's really county specific. A lot of
mhm,
people think that like the federal government has created some magical textbook or map for how to approach this process. And they have it in a lot of sense. So correctional facilities are operating within the means and um, uh,
the
logistics
guideline.
of
Right.
individual counties. I think Orange County is a perfect example.
Correct. Dr. Clayton Chow, who is currently the public health director, medical director, is a very is an avid proponent of implementing the community standards and actually above and beyond in the correctional setting, and mainly due to the fact that this is a vulnerable population who may otherwise not benefit from the same guidance, education, and access to resources when they are in the community. In addition to being the vulnerable population, they also are at high risk for infection due to homelessness and again, comorbidities that put him at high risk for mortality. So in that respect, I'm really glad to see that the correctional health services actually have been a bit of a step ahead the community standards. So the provider options in the correctional health, in the correctional facility, of course, registered nurses are the gatekeepers of healthcare delivery flow. They do receive the self-referral slips or medical message slips that received from the jail population, read through them, assess the immediacy and determine the, again, the immediacy of their needs, schedule the individuals for sick call, and perform a variety of healthcare delivery services based on the protocols existent for the registered nursing staff in the jail. They may be a little more autonomous than other registered nurses in the hospital or in a nursing care home, but they do follow strict protocols and procedures based on handing out over-the-counter medication or doing wound care. And of course, there's a very good process of referral to the medical staff, to the healthcare provider staff, such as nurse practitioners and physicians. The licensed vocational nurses administer medications and assist with a variety of office procedures, monitor vital signs, and also collect data for the clinical tools that we use in the detox protocols for alcohol and benzodiazepine, the detoxification. Um, Physicians and nurse practitioners provide in a collaborative fashion a comprehensive plan of care for the patients referred by the nursing staff. Medical providers assist with treatment and management of chronic conditions. We order in-house diagnostic and screening tests and also make appropriate specialty referrals. The psychiatrists and psychiatric mental health NPs address the mental health needs of the population. with diagnosed mental health disorders through risk assessment and psychopharmacology management. We also have, I forgot to mention this year, but we have a staff of psychologists and licensed marriage and family therapists and licensed social workers who are providing group therapy. Sadly, last year that was reduced to a very minimal intervention because of the safety imposed by the COVID protocols. However, we are now beginning in certain areas to revive the group therapy for individuals with severe mental illness. Okay. In addition to the in-house staff, we do contract with 3 major areas hospitals to provide tertiary care for acutely ill patients and also coordinate transition to jail after stabilization of their health status. The CHS has a comprehensive network of specialists who complete the compendium of healthcare delivery elements. We have orthopedic surgeons, ophthalmologists, cardiology services, hematology, oncology, endocrinology, neurology, general surgery, OBGYN specialists who are providing care either in remote clinics or through telecare, medicine in the in-house clinic. And sometimes they do visit the clinic and at the main jail. Okay, and in addition to that, we have podiatry care as well. That's something fairly new, and optometry. The medical and mental health care needs of the jail population are met routinely on a chronic, we also address the chronic conditions. We do annual screenings and also address the various healthcare needs on a self-referral basis. The chronic diseases such as diabetes, hypertension, asthma, endocrine disorders, and seizure disorders are monitored and treated in-house and also referred to specialty clinic as indicated if the complexity of the testing or pharmacology exceeds our ability to provide the care needed. Diagnostic testing such as x-rays, EKGs, and other laboratory testing are done in-house. So we also have laboratory services performed by UCI lab, Quest Labs, and the public health lab. Urgent medical conditions are addressed by the medical staff and referred to contracted hospitals, of course, if the level of care requires such intervention. Patients are screened for opiate disorder, use disorder, and initiated on the medication-assisted treatment with Subutex, Suboxone, and Sublocade. And the screening is done at each booking. It is confirmed with in-house drug screening that we use and based on their history. We do not have drug screens that capture the use of fentanyl, and fentanyl, especially the chemical compounds that circulate in the community now, are not easily tested on the drug screen test that we do have in Orange County Jail. So nevertheless, we do assess that the individuals who report fentanyl use in a community and provide the medical assisted treatment. All our providers have the X waiver, and we are all able to order the Subutex, as mentioned, Suboxone, and have Narcan available in all men down bags. It's called a men down bags, kind of a vernacular way of saying of addressing the a bag that we use when we respond to emergent situations anywhere in the jail. And Narcan has been supplied as well as other, rapid intervention medications to like EpiPen, for example. Methadone treatment is continued by the clinic managing the client at the time of booking. If they do report that they are under treatment for opioid use disorder with methadone from one of the county clinics, we do contact them, and they will provide doses, a continuity of care. Security and medical staff have access to intranasal Narcan to use in cases of overdose. Those are fairly common for individuals who come into jail and may have ingested a larger amount of drugs at the time of the arrest to escape heavier charges. And eventually, after a few hours of being in the loop or waiting to be processed, they may have an opiate overdose. So the addition of intranasal Narcan as well as intramuscular Narcan, as well as education of staff on how to use this medication has helped save a lot of individuals. We also screen for alcohol and benzodiazepine abuse, and implement detoxification protocols by use of clinical scales and a very strict protocol of detox with a benzodiazepine called oxazepam or Cirex. Oops. And I have, this is the end of my presentation. I have chosen this quote from St. Francis of Assisi because it captures so much of what we do in jail. We do serve the least, the last, and the lost. And this is a statue of homeless Jesus. And thank you so much for your attention and for your interest in this presentation. And now I am ready to for questions and answers. I'm going to start the share. Okay.
Okay, so there's a lot that the correctional system captures. We've talked about how there are a lot of different holes in our existing system. And outside of even just the existing healthcare system, there are a lot of holes in our general population's access to necessary services. That might include housing, food, treatment of disease, etc. And the correctional system ends up being the de facto safety net for a lot of those ills. And so I hope you understood and could pick up on how intersectional delivering care in a correctional setting really is, because you're managing, we talked about communicable disease, substance use, the health effects of being unstably housed or unhoused, the health effects of criminality itself. All of those things a provider in correctional systems have to be versed in and have to be ready to treat. They often outsource when some of those needs might be greater than what can be met inside of the actual correctional facility. And we talked about how some of those partnerships manifest. But I hope people can see that it's not just one condition, one type of patient, or one disease process, if you will, that is being treated and cared for in correctional settings. You heard a case study for Orange County, but just know how we as Orange County have decided to pay for services, develop contracts with other providers or health systems is county specific. And so wherever you may be coming from, wherever you might be going for residency, wherever you're currently practicing, the makeup of providers in your county's correctional facility might look different, but Orange County's is not uncommon for the County Department of Public Health to be overseeing the majority of what goes on in terms of healthcare services in the jail. That's not uncommon. So if people have individual questions about individual states, then by all means ask them, but just know that this was pretty Orange County specific.
Right.
Yeah, what questions, if at all, can we field for folks in the larger context or conversation around correctional health or healthcare services that are offered? You might have also seen that we ran a poll at the beginning of this session just to gain kind of your thoughts about where these services are delivered and how. We could also share some of those results reads if anyone did participate in the poll.
Yeah, so for the polls, we had about 4 to 5 people participate. Let me pull up the results again. And most people thought for, in terms of who provides incarcerated people, like where do they receive their care, everyone agreed that they receive most of their care from the jail. In terms of the agency that provides healthcare in Orange County, most of our classmates said the OCHCA. And then for some of the other polls, I don't think people got to them, but yeah.
Great.
Okay. Thank you, Kelly, for providing the additional footnotes for and clarifying, what the MAT, medication-assisted treatment, and you are correct. The correctional healthcare system, and I'm sure that Orange County corrections reflects very much, if not nationwide, I mean statewide, nationwide, how important it is to fill in the gap of the disenfranchised population. We do address the mental health issues and substance abuse in at a higher percentage than any other system of healthcare delivery in this, county, city, nation, you name it. It is quite staggering. It is can be very challenging. And it is very difficult as a provider there to reach that sense of goal attainment because I capture them when they're very vulnerable, when they have already fallen through so many hoops, through so many holes of the net, of the safety net that should exist out there. That for the most part they lack trust into what we can offer, and also there's the lack of continuity because we are trying to fill in those gaps and sort of create that chain of continuity to prevent recidivism, and this is where JCRP comes into place. However, it is very difficult because a list of resources or a bus pass or a word of encouragement is not enough when there's other greater societal factors in place that act as deterrents for their reintegration. And unfortunately, substance use in combination with mental health disorders occupy a great deal of what we are faced with in terms of healthcare delivery services in the jail. I'd be happy to answer any questions.
I don't necessarily have a question. It's more of a comment.
Mhm.
A lot of our medical student experiences with psychiatry, we see a lot of patients who do have a history in terms of having been formerly incarcerated, or after seeing us, they become incarcerated. And I've seen this pattern a lot where because once they go to jail, they have the mental health services more readily available to them, they actually become better. And then it's the time that they spend outside where they have less of the structure, where their mental health sort of deteriorates. They don't have as good of access to the medications that they need in order to remain stable. And I think that in terms of my personal experiences, that was one of the more difficult things to accept in terms of our healthcare system, that really shouldn't be the case. Someone who needs those mental health services should be able to receive them before they get to the point where they end up getting in trouble and go to jail. And if they do get to that point, they should be able to have a nice transition back to society and still receive their medications. And too often we see people fall through those cracks.
Right. No, it's very, very true. Yes, I have seen, given enough time and, as you said, structure and a predictable environment, individuals with mental health disorders manage to reach a state of functioning that would be somewhat reintegratable in the society at large. But there's still so much more guidance that they do need out there. And unfortunately, some of the resources available in the community are not very well coordinated to address all the factors, all the components that make for a replication of the, let's say, incarceration into the community, such as stable housing, checking in on them, to address factors such as loneliness, helplessness, the maybe a job that would bring some sense of fulfillment and community. Yeah, so these are sadly issues that are very, very difficult to address and plague a lot of individuals. And just as COVID has unearthed, has unmasked, and has shown with such blatant force the economic and social disparities that exist in the United States at the national level. This is how basically this pandemic has affected so much more the vulnerable population, the individuals who had pre-existing conditions, who had substance use disorder, who were not able to hang on to a stable job or housing in the community, have definitely suffered immensely in the past year. Yes, here we are to fill in that gap as best as we can.
Well, we thank you for your contributions to incarcerated people. I continue to define myself as an abolitionist, but I think it is inherently abolitionist to offer services that are not otherwise offered in the community. I think that's a whole other discussion that we could have, but I think you bring a really necessary and refreshing light to what we otherwise see as a pretty drab system to exist and work within. I hope people here understand that working in this arena is possible. If we had to define anyone as in need or marginalized, it's certainly our incarcerated brothers, sisters, and siblings. So thank you, Dr. Aamot, for your work and for being with us for the last 2 years. We appreciate you.
Oh, thank you so much. And to to the audience, to the students and the upcoming healthcare providers, physicians, and nurse practitioners out there, and nursing staff. Thank you for considering this. It's this presentation. I hope it, in a way, sheds some light into how public health care delivery is done in a very unique setting. And how important all of these elements of healthcare delivery are, really. Thank you again.